There's a burning sensation that crawls up your chest after eating. Or maybe you don't feel that chest burn at all, but instead there's something stuck in your throat, a thick, sticky mucus that won't clear no matter how many times you try. It feels like two completely different problems. One gets labeled as acid reflux, the other gets dismissed as allergies, or anxiety, or just one of those things. But in many cases, they share the exact same mechanical cause, a valve that isn't closing properly. The issue isn't always that you're producing too much acid. In fact, more often than not, the real problem is that the security door of your stomach has been left slightly ajar. And here's something that tends to surprise people. It's entirely possible to have reflux without ever feeling that classic burning sensation. If you've already watched the previous video on mucus and the role of baking soda, welcome back, because you already have a fire extinguisher to manage the immediate symptoms. But using that extinguisher every single day doesn't put out the source of the fire. So today, we're moving past the temporary fixes and going deeper. The goal is to understand how to reinforce this valve so that the backflow stops, and so that you can move away from depending entirely on medication. To solve this, there's one core idea worth internalizing. Your stomach is not simply a bag. It is a pressurized reservoir with variable internal pressure. Picture a balloon filled with liquid and gas. If you squeeze it, the contents push upward, trying to escape. What prevents that content from traveling up from the stomach into the esophagus is a small circular band of muscle at the junction between the two, the lower esophageal sphincter. Think of it like the knot at the top of that balloon, or like a plumbing valve. The problem is that this door can fail for several reasons. Sometimes it opens due to distension and pressure changes inside the stomach. Sometimes the muscle itself relaxes at the wrong moment. And sometimes a hiatal hernia weakens it structurally, allowing content to migrate upward. There's a misunderstanding that comes up repeatedly, and it's worth addressing directly. The goal is not to eliminate stomach acid. Acid is essential. It kills harmful bacteria, it breaks down protein, and it's necessary for proper absorption of vitamin B12. Acid isn't the enemy. The problem is simply that the acid is on the wrong floor. Instead of staying where it belongs, it's traveling up into the esophagus and all the way to the throat. That happens because the gatekeeper, the valve, has lost its tone or simply stopped doing its job. An important distinction here: proton pump inhibitors, like omeprazole, do reduce the acid assault and can effectively heal esophagitis in many people. They're a legitimate and often necessary treatment when there's actual tissue damage in the esophagus. But omeprazole does not mechanically reinforce the valve. It doesn't close the door. And in certain cases, especially when the reflux isn't acid-based, or when the sphincter is significantly weakened, throat symptoms can persist even when acid levels are well controlled. That's exactly why today's focus is on reinforcing that door mechanically. So, what causes the valve to open when it shouldn't? Let's look at this from a fluid mechanics standpoint, or, if you prefer, a plumbing standpoint. A hiatal hernia can be a factor, but very frequently the trigger is stomach distension and the pressure mechanics that follow. There are essentially two mechanical plumbing errors worth understanding. The first is overfilling, and, for this, a simple guideline applies: the 80% rule. The stomach is a muscular organ, but it has a capacity limit. When you eat past the point of fullness, gastric distension increases internal pressure, and that pressure can overcome the resistance of the lower esophageal sphincter. It's basic physics. Pressure finds an outlet. And this doesn't just apply to food. If drinking large amounts of fluid during meals consistently worsens symptoms, it's because the volume of the reservoir is being pushed too high. More volume means more pressure against the valve. The solution here is simple in concept. There's an old Japanese principle called hara hachi bu, the idea of eating to about 80% of fullness. The point isn't to count bites or become obsessive about portions. It's a practical reference for recognizing the "I've overdone it" threshold before it happens. Stop eating when hunger subsides, not when you feel stuffed. And if large amounts of liquid with meals are clearly triggering symptoms, shift the bulk of hydration to between meals rather than during them. The second mechanical error is what could be called an inverted gravity problem. This is one of the most impactful and most accessible changes available, and it comes down to anatomy. The stomach has an asymmetrical, J-shaped structure. Valve is already weak, it opens. But when valve is already weak, it opens. But when lying on the left side, the stomach hangs below the esophagus. This creates a kind of natural safety pocket. Liquid stays pooled at the bottom, and gas has a harder time moving upward. For anyone dealing with nighttime reflux or morning throat congestion, sleeping on the left side, when comfortable and feasible, can be one of the most effective single interventions available. If that's not possible due to shoulder or hip discomfort, or if staying in that position throughout the night is simply difficult, there are equally powerful alternatives. Elevating the head of the bed by approximately 6 inches using risers under the legs of the headboard, not just adding extra pillows, makes a measurable difference. And avoiding lying down until at least 2 to 3 hours after the last meal gives gravity the time it needs to do its job. The principle throughout all of this is the same. Gravity is an ally, and using it effectively costs nothing. Now, let's talk about chemical sabotage. Beyond physical pressure, certain substances don't cause acidity directly, but do cause the lower esophageal sphincter to relax its tone. If the goal is to reinforce that valve, eliminating 4 classic relaxants for 2 to 3 weeks is a worthwhile experiment. First, peppermint. It may seem like a digestive aid, and in some contexts it is, but peppermint has a well-documented relaxing effect on the sphincter. Peppermint teas or lozenges after meals are better avoided when reflux is active. Second, chocolate. This one is difficult to hear, but the combination of theobromine and fat in chocolate is a known sphincter relaxant. The practical approach is to eliminate it initially, observe the results, and later reintroduce it carefully to find a personal tolerance threshold. Third, alcohol. Even a single drink in the evening relaxes muscular tone and can allow the valve to stay open during sleep, disrupting the night significantly. For active symptoms, eliminating alcohol entirely is the more effective path. Fourth, tobacco. Smoking directly reduces sphincter tone, and the effect compounds with each cigarette. Everyone weakens the barrier further. And stopping is the only real solution here. As for coffee and tomato-based foods, the evidence is more variable. For some people, they worsen symptoms by irritating the lining or stimulating acid production. For others, there's no noticeable effect at all. The reasonable approach is to eliminate them initially if symptoms are severe, then reintroduce them one at a time and observe how the body responds. Now for the repair protocol. Perfection from day one isn't necessary, but a system is. There are 3 levels to work through. Level 1 is dietary and mechanical control. Eating the last meal of the day, 3 to 4 hours before bed, significantly reduces the likelihood of nighttime reflux. The stomach needs time to empty in an upright position with gravity assisting. Going to bed with a full stomach tips the balance against the valve. Lighter evening meals reduce both volume and pressure. External pressure factors also matter. Excess abdominal weight increases pressure on the stomach and worsens reflux. So weight management is directly relevant to symptom reduction. Tight clothing around the midsection, including belts and waistbands, has the same compressive effect and is worth avoiding. Bending forward immediately after eating also increases intra-abdominal pressure and is better delayed. Level 2 involves external support through alginate-based products. When the valve is significantly weakened, for example in the presence of a hiatal hernia, dietary changes alone may not be sufficient in the early stages. Alginates, such as Gaviscon and similar formulations, work differently from antacids. Rather than neutralizing acid, they form a physical raft, a floating barrier on top of stomach contents that mechanically reduces upward reflux. These are typically taken after main meals and before bed. One practical note: avoiding large amounts of water immediately after taking alginates is advisable as it dilutes the barrier. Waiting a short while before drinking is the better approach, though a small sip is unlikely to cause problems. This was covered in more detail in a previous video. Level 3 is local protection, relevant when throat symptoms are the primary concern. Mucus, chronic throat clearing, or laryngeal reflux. If the throat is the main site of irritation, adding alkaline water gargles or baking soda gargles, as explained in the earlier video, helps neutralize pepsin that has already traveled up and adhered to throat tissue, where it can continue causing damage when activated by acidic foods. For anyone currently taking omeprazole, pantoprazole, or similar medications prescribed for esophagitis, Barrett's esophagus, or ulcers, these mechanical strategies are complementary, not replacements. Stopping proton pump inhibitor therapy without medical guidance is not appropriate. The aim here is to reinforce the mechanical side so that over time, in collaboration with a physician, medication can potentially be reduced or phased out safely and gradually. These medications are necessary and effective when there is existing tissue damage, and any changes to them should happen under supervision. A few frequently asked questions on this topic. Apple cider vinegar. It comes up often. For individuals with genuinely low stomach acid, it may help support digestion, and there are real discussions in the literature about its role. But for anyone with active burning, pain on swallowing, esophagitis, or ulcers, applying acid to an already irritated surface will increase pain and potentially worsen the injury. Starting with apple cider vinegar in the presence of active symptoms is not a good entry point. On the question of whether reflux can be resolved permanently, if the root cause is lifestyle related, meaning dietary habits, excess weight, or chronic stress, then correcting the mechanics often allows the valve to recover a significant degree of function, and the problem can genuinely be resolved. If a moderate to large hiatal hernia is present, however, mechanical management becomes a long-term maintenance strategy. Surgical options are evaluated when symptoms remain refractory despite optimal management, when complications arise, or when quality of life is severely affected. But the decision depends on a broad range of clinical factors, not on anatomy alone. And if throat symptoms don't improve with all of these strategies, it's worth knowing that not every case of chronic throat clearing, mucus, or cough is reflux-related. Postnasal drip, asthma, laryngeal hypersensitivity, and nasal drainage can all produce similar symptoms. Certain blood pressure medications, specifically ACE inhibitors, like lisinopril, enalapril, and ramipril, are a well-known cause of chronic cough and throat irritation. If 2 to 3 weeks of strict adherence to these recommendations doesn't produce improvement, evaluating other causes with a physician, and potentially with an ENT specialist, pulmonologist, or allergist, is the appropriate next step. Red flags. Knowing when this is no longer just reflux. There's a clear line between managing symptoms with mechanical strategies and needing prompt medical evaluation. Seek medical attention urgently for progressive difficulty swallowing, severe chest pain where there's any uncertainty about whether it's cardiac, vomiting blood, or material with a dark coffee ground appearance, unexplained weight loss without dietary changes, unexplained anemia, or very dark or tarry stools, which can indicate upper gastrointestinal bleeding. These signs may point to Barrett's esophagus, a precancerous change in the esophageal lining, an esophageal ulcer, a stricture caused by scar tissue, or, in rare cases, malignancy. If any of these are present, mechanical strategies are not the starting point. The starting point is prompt evaluation by a physician, including endoscopy if indicated, a procedure that allows direct visualization of the esophagus and stomach. Do not delay that conversation. The stomach is ultimately a machine. A pressure variable balloon with a safety valve, ignoring how that mechanism works, tends to produce predictable problems. Respecting it tends to produce results that are faster and more lasting than most people expect. Start with one thing. Finish dinner 3 hours before bed and sleep on the left side. Or if that's not an option, raise the head of the bed and see what changes. That single adjustment alone can substantially reduce the probability of nighttime reflux. And if reflux comes with persistent throat mucus, chronic clearing, or a morning cough, the previous video on pepsin and baking soda explains exactly how to address what's already accumulated in the throat, because reinforcing the door mechanically is the first step. But if pepsin is already active in the throat tissue, that requires its own targeted approach. There's also a dedicated video on hiatal hernias for anyone looking to go deeper on that specific piece, and a pinned note in the first comment about omeprazole. Take care of yourself, and I'll see you in the next one.